Hello and welcome to Insight, which is a collaborative interview series and a free online knowledge resource. Today, we have with us on Insight Dr. Sylvia Karpagam. Dr. Sylvia Karpagam is a public and community health doctor and researcher who has been working on access to healthcare for over 2 decades. This includes regulation of the private sector and on the social determinants of health. She has worked on issues related to policy through research, training, and writing, as well as speaking to the media. She sees caste as an important determinant affecting health and nutrition, and as well as being a steady, state-sanctioned oppression of the most vulnerable among us. She has provided an alternate perspective on how to look at health as something else rather than just a purely curative hospital-centric model. She has worked with communities, healthcare workers, activists, lawyers, and researchers to build evidence for advocacies with policymakers. A prolific writer on caste, nutrition, health, and the lives of people who are often overlooked by the mainstream narrative, she is a clear-eyed warrior of grassroots healthcare, and to top it off, she is also an artist of considerable ability. Dr. Sylvia is someone I have observed up close at different times over many years, and what has struck me most deeply is her level of genuine affection and mindful engagement with each and every person she speaks with, as well as her consistent follow-up on a palette of issues and cases that would make most of us weak in the knees to even consider. Without further ado, let's dive into what promises to be a revealing conversation with Dr. Sylvia Karpagam. Good afternoon, Doctor, and welcome to Insight.
Good afternoon, Hari. Thank you so much for having me on the show and for that really wonderful introduction.
Yeah, you're very welcome. To dive straight in, Doctor, could you please tell us a little bit about the areas that you work on under public and community health?
So my background is in medicine. So I did my MBBS from St. John's Medical College, and then I went on to do my MD in community medicine. Community medicine looks more, of course, the clinical and the curative part is one part of it. We're trained to have also be primary care doctors. But there's also the research component, there's a capacity building. We're trained to look at policies and programs of the government. I was also with the NHS in the UK, like very briefly for some time, and came back to India and worked with a couple of organizations. But I think over time, I began to realize that health is not just hospital-based curative kind of model. There are multiple determinants, what we call the social determinants of health, which clearly impact on both the health outcomes as well as access to healthcare. This is what I started engaging more and more. I mean, it came in an organic way, and the private sector is something that is keeps rearing its head on in different ways, and looking at that, trying to understand that issues around regulation, conflict of interest. Those are the main areas that I'm kind of interested in.
Okay, Dr. Sylvia, could you just tell me the kind of work you've been doing around COVID-19?
So even before the COVID pandemic related issues started, and before the lockdown, a group of us have been working around the NPR, the NRC, and the CA. For those who wouldn't know, there is this whole government initiative called the National Population Register, which was which had created protests across the country for the last several months. It was mainly like targeting the Muslim community in India. So a group of us had anyway come together, and we had been working on that. So it kind of organically also, it's like some of the members moved into relief work, and some of them have been working with the migrant workers quite closely. And like I was looking at the health part of it, and there are a group of us who also looking at what's happening to health situation, both of people who are diagnosed with COVID-19,
Right.
people are suspected, like what's happening to the quarantine centers and those so-called, I mean, I should say so-called quarantine centers and so-called containment zones, because they weren't really following any protocols as prescribed for this, you know, it's a public health initiative. It's a public health initiative, but it wasn't being followed in terms of the protocols.
Okay.
And also, what is happening to the non-COVID cases, like just because COVID happened, it doesn't mean that all other health issues suddenly disappeared and magically said, let's wait
Right.
while the government and people are dealing with COVID. Of course, all those things, whether it's tuberculosis, malaria, HIV, deliveries, emergencies, heart attacks, everything is continuing to happen.
Right.
So we were looking at those, what is happening to those things. And also, like I said, the social determinants, overnight people lost livelihood, they lost income, they lost food, they lost dignity, the whole psychological impact of this. So we've kind of been trying to document that. And also, this pandemic and the lockdown has thrown up what was already there and was kind of invisible, especially to this very the middle class is so blissfully unaware of what's happening to the country around them. So
Right.
I think suddenly they woke up and they're like, hey, what's happening to our public health system, meaning what was always there all along is
Right.
suddenly become more visible. So we're trying to document it, working with whatever the people who are already there and trying to build at least some evidence, going forward, what are the lessons to be learned, what are the gaps, how can these gaps be plugged. So that's the kind of thing that we're kind of doing.
Sure. Yeah, I'm going to press you on those specifics in a short while. So, but just so that I'm understanding you correctly, what you're saying is that you were dealing with a healthcare system that already had inherent flaws, and that of course was still under a lot of stress dealing with the general run of diseases, lifestyle and otherwise contagious diseases that anyway the healthcare system has to deal with. But now the COVID is just one more additional burden, but a big burden that has been placed on an already uh, fragile and maybe flawed system. Is that right?
It is. One is it is an additional burden, but it's also about in responding to this COVID-19. Like, how are you affecting those other
Right.
systems that are already so fragile? And if you're a planner or a policymaker, you have to make choices. And like, what influences your choices? Is it short term? Is it long term? Are you looking to learn from it, or are you just responding to some populist kind of pressure and doing things? So I mean, yeah, it's more than just what is happening to the other conditions. It's also how the decisions are being made and the possible outcomes of those decisions.
Right. And like you said, like you mentioned earlier, the social determinants of those decisions as well, which are wide reaching for a large section of the population, many of whom have no recourse to a lot of things right now, as we've all been seeing in the news.
Yes.
So what you're saying is that maybe the healthcare system wasn't very well prepared for this in the first place. But what do you think are the learnings right now? You've now observed it. You've been observing it pretty closely. You've spoken to, I'm sure, many public health specialists and many other people who are working on the front lines of COVID-19. Are there any early learnings that you can share with us at this point, or is it still too early to say?
Yeah, I mean, there are some things that we already knew, and they kind of become a lot more visible.
Sure.
And of course, there's some things that the pandemic has brought up, but also specifically the lockdown itself has revealed quite a few things. So even before this pandemic, I think there was a concern about how healthcare was becoming very centralized and very commercialized.
Right.
The private sector was playing a very predominant role in healthcare, especially in Karnataka. And
Okay.
this idea of healthcare being centralized, it's an important issue, because now when you're asking people to have physical distancing, you're cutting down public transport, and you're also saying test. How do all these things work together? If all your testing facilities are somewhere in Bangalore, then how are people across the state going to access this facility? And the way the private sector grows, it's not a healthy competition, as people always say. They say the private and public should compete with each other. But imagine a group of people, why would they go and access a paid facility like a private sector, which is centralized, if they had like good public health facilities, if they had comprehensive care, close to where they live, they had access to lab tests and they access to essential medicines. So the only way you can strengthen a private sector is by destroying the public health sector. And I think that's what we've seen across the years. The primary health center was literally the hub of all medical activity. It was also preventive, it was also rehabilitative, it was curative. You had all the national programs converging at the primary health center. You had a medical officer there. It was fully equipped with the lab technician, the pharmacist, the field workers. It catered to a population of about 30,000. So
Right.
within that population, it was pretty much self-sufficient. It was also almost an independent administrative unit. But the kind of the decisions that have been made,
Right.
it broke that whole public primary health center facility, and it happened even to the secondary level facilities. And it's such a tragedy that even the district hospitals in many of the districts are not able to meet the healthcare needs. It's meant to be a self-sufficient, independent unit, the
Right.
district. But with kind of complicated tertiary level cases being seen at the district hospital.
Right.
But over the last few years, even for simple things, people have had to come to the towns and cities. They've had to spend out of pocket, and in fact, health expenditure for the cause, it's called catastrophic health expenditure, because people take loans and
Right.
they sell land and they sell assets, sell livestock, only to access healthcare.
And these are
So
life changing for some people, where they can't go back to their original way of life purely because of a healthcare issue.
exactly, it pushes someone who's above poverty line into a below poverty line person.
Right.
That's why
And
it's called a catastrophic health expenditure.
okay. And and these catastrophic health expenditures have been happening pre-COVID as well. So this is it's basically something that's been happening for many years now, as you've described. And now suddenly,
Yes.
with this already overwhelmed system, which where so many people are forced to to the point of a catastrophic expenditure, having to come to a city, the nearest city to them. Now you've just got this huge behemoth of COVID added on top of this system.
It's been added, and so the task force which was created in Karnataka for COVID is predominantly people from the private sector. And see, this idea of saying policy or policy maker, I
Right.
don't think it's really true. I don't think it's really there in reality. So if you see the people making decisions for healthcare, it's people who directly benefit. So either they benefit financially from it, or they benefit in terms of getting, becoming experts, so-called experts, who then go and make their money by speaking at different fora, international and national fora, or they do research on it. But the people who actually use these systems figure nowhere in decision making.
Right.
And in fact, there's very little even um, government officials who are actually making the decisions. So it's very corporate led.
What you're alluding to right now is a very clear conflict of interest, where you have
Yeah.
people who stand to directly benefit from certain policy changes or certain decisions that are made, advising the government on those same policy changes. So then, once,
Yeah.
of course,
Yeah. Yes.
once they have a very firm hand in what decisions are taken, they also have a very clear way of benefiting from those decisions. Yeah.
I remember the point I wanted to make is that it's a of concern that the even the existing super specialty hospitals, like we have some very well-renowned super specialty hospitals for cancer. We have the Kidwai Hospital, we have the Victoria, the Vani Vilas, you have the Kidney Institute. They are being converted into almost secondary level COVID-19 facilities, which is putting the existing patients into a lot of difficulties. So you hear about cancer patients who've been discharged and said, go home, come back after the lockdown. Just last week, we heard about a very young person who had a mediastinal tumor. The note say that it requires urgent intervention,
Right.
a malignancy, life-threatening,
Right.
and that person has been told, go home and come back after the lockdown. And if you see the recommendations put forward by these same private sector players, they're saying the government should invest in private hospitals, like you set up ICUs and set up ventilators, set up lab testing facilities in private sector.
Right.
So there's a need, but then see who's capitalizing and who's benefiting from that need. That I think is something that we should really be very concerned about.
And also, of course, like you said, at the end of the chain, there is there's a human being, a patient who's undergoing probably the most difficult moment in his or her life. And in the middle of that, they're forced to, reckon with this sudden, blanket change in policy that basically robs them of a level of healthcare that could, in many cases save their lives, if not ease
Absolutely,
the
yeah.
pain and stress that they're going through. So it is,
Absolutely.
yeah. So then it sounds to me, Sylvia, like the government has placed the responsibility mostly on citizens, many of whom are vulnerable, rather than have a clear mandate that benefits those who are most affected by this. So you've told us very clearly about the public sector. I mean, the private sector. I apologize, and what kind of a role they have had to play in this. But what about the government's role? And what have they really done other than sort of make an already difficult situation more murky and more difficult?
I think the way the government has interpreted a lockdown is that the government itself goes into a lockdown. Suddenly, even existing government structures have stopped functioning. So when this whole crisis, when people lost their jobs and asked to stay at home, they had no access to food.
Right.
We actually called the food commission, and he said we're all senior citizens, and we've been asked to stay at home. So literally that was what was happening. The government wasn't accessible. Nobody was answering phones. They weren't going to the field, and so the whole idea of lockdown has been interpreted so differently by different people. Like the police saying, "Hey, it's a good time to pick on all the people we dislike and start beating them up." Then you have the government which is saying, just stay at home. It doesn't matter if you don't have rations, or even if you're falling sick, but stay at home. So, but if you look at the government health system, the government machinery, it has been the only system that has been functioning to some extent. Although what is very clearly visible is that it's clearly underfunded, it's clearly understaffed. There's very poor resources that have been invested. They don't have access to even basic protective equipment. The ASHA workers, unfortunately, are, of course, people call them the frontline workers, but it's very sad that in a country, such a big country, the burden of healthcare is being put on these women who are some of the most vulnerable, some of the poorest women, in the system. And every time there's a problem, it's the ASHA workers who are getting affected. It's ASHA workers who are not getting paid. They're the ones who are depend on incentives. They don't even have a regular salary. So the system has pulled its weight to whatever it can do, but clearly that's not good enough. We don't have enough testing facilities. We don't have enough human resources. We don't have enough infrastructure, and definitely we don't have it in the peripheries. It tends to be quite centralized in
So
terms
the
of access.
So the more we go into the margins, and we don't mean just margins in urban areas, but margins in rural areas and beyond, small towns and beyond the the urban centers of healthcare. The more we find these large glaring gaps between the needs and what is being provided in order to sort of keep the situation in some element of control. Recently, you had
Yeah.
written about about Taiwan and a couple of, I think, New Zealand and a couple of other countries, and the way they have handled this health crisis. Uh, could you tell us a little bit about what we could learn from these other things? Could I be so bold as to include Kerala in a positive example of how a situation, health crisis like this, can be dealt with? Or because a lot of people are holding up Kerala as a big example in India, at least. Is that right, first of all?
Yeah.
And also, what can we learn from other countries around us?
So while it's important to learn from other countries, I think it's also important not to replicate without looking at the local context,
Sure.
because that is a problem. You say in Italy they're doing something, so then you just cut and paste the same thing into India. It's not going to work.
Right.
And even within states and within districts, there's going to be a lot of variation.
Right.
So, for example, in Kerala, they already have a very strong system. They have people who, in many ways, are equal participants. They're not. It's not a top-down system where you just enforce things on people. People feel the need to participate. You have a lot of community structures. You have the community kitchens. You have a government that is ready to plan and is also proactively disclosing their plans to the people.
Right.
It's planning in advance, and even if one wished for a Kerala model right now, say in Karnataka or in Maharashtra, it's not going to happen because the structures don't exist for that kind of a response. But definitely, one can learn from it, and one can look at different models, and one, I think, should consult with multiple stakeholders and also look at long-term consequences of decisions that one makes. You can't say that we reduced COVID-19, but in the process, hundreds of people died due to other conditions.
Right.
It doesn't, it shouldn't work like that. So the I think the lessons from both Taiwan and Kerala is uh, about, it wasn't top down. It involved people. There was a lot of participation, and definitely, I think that's a very important aspect of handling a pandemic. Information has to be put out to people. The people who are most affected should be very primary players in decision making. They have to be involved. You shouldn't have this middle lobby of people who are not affected, who can afford to sit at home and then say, like, pass an order that everyone should sit at home, because they're clearly not connected with what's happening to the rest of the country.
Yeah, and I think you brought up a very, very important point of self-determination, and also people, the people who are affected being represented, sorry, adequately in in these decisions that are made. And in terms of Kerala, I guess, yeah, like you said, a robust grassroots level healthcare system, as well as a robust system at the grassroots level across the state that localizes power rather than centralizes it, has shown over a period of years. This is not something, as we all know, that has happened overnight or for COVID specifically. This is something that they have incorporated, and now they are reaping the benefits of a system that they have put into place, years before, and have tested over many years with other sort of epidemic situations as well.
Yes.
So, like you said, this might not be a cut and paste or a copy paste. Let's not cut it out of Kerala, but a copy paste situation.
Copy-paste, yeah.
But this is something that other states could maybe learn for future reference and how they could, overhaul their own systems with healthcare and other aspects of local governance. And, therefore, when a situation like this really hits, they are in a better state of preparedness in a local level and with a greater and a much higher, clearer level of communication, which I think is another thing that's been lacking from the central government, where clear communication has also made it much easier for people, at a individual level to sort of know what is expected of them and what they can and cannot do to make the situation better. So so in order to move on, I'm just going to quote from one of the things. Sylvia, as I've mentioned earlier, has written many articles, which I will attempt to share a lot of links, on my website when I share this interview, so you guys can go and check out all her writing. But in one of her recent articles, this is what she said, and I quote: "In India, there is evidence that target setting, punitive action, and hierarchical structures lead to magical drops in numbers. We have seen this with family planning, institutional deliveries, maternal and infant deaths, tuberculosis, HIV, malnutrition, dengue, malaria, manual scavenging, lynchings, domestic violence, and dowry deaths." Now, that's a wide range of issues, but issues that affect millions of people across the country. So it makes me ask this question. Of course, the quote is over a couple of sentences ago. Is this system hopelessly rigged, or is there any ray of hope that we have that, that all this range of issues can be dealt with in a more, I don't know, I'm scared to say compassionate way, but in some sort of an effective way?
So we have always worked in a kind of a competitive, target-driven mode, and the people who are working like so-called frontline workers, they always set targets, and they told, like, if within this period of time you have to do this many cases, you have to identify this many people with tuberculosis, you have to have so many women delivering in institutions. We've seen with a lot of programs where this suddenly the government decides that you have to show success in certain diseases. You have to show that a program has worked, and especially when data starts coming out and when some states start looking bad, then there's a scramble to kind of show that we're not as bad as the numbers indicate. So then these kind of top-down interventions are put into place. Targets are set, and the burden of it is put on the frontline workers, where they're told you have to bring down maternal deaths to from 6 in this area to 0. And till it comes to 0, there's a pressure on them. They're pulled up in public, they're humiliated, and disincentivized. So what happens naturally? It's like it's like a school. It's like school children. They do anything to kind of get away from trouble, and it tends to be punitive. Instead of saying, like, why are these pockets showing these kind of numbers? Like, what's happening? Why? Like, for example, if you took, say, maternal deaths, why are the maternal deaths happening? There is actually systems in place where you're supposed to do kind of a verbal autopsy, where you go back each time a maternal death happens. The district collector has to come. You look at all the ways in which this maternal death could have been prevented, and you try to plug those gaps. But that doesn't happen. It's always very top down. People are punished, and therefore the numbers itself that comes out it tends to be very unreliable. Whether it's institutional deliveries or maternal deaths, child deaths, or malnutrition. So if an Anganwadi shows that the children who have severe acute malnutrition is high, then she gets punished or she gets pulled up. The media also kind of jumps in and says, this Anganwadi has so many cases of malnutrition. So naturally, there's no reason for people to put out accurate data because they're going to be punished.
Right. So so basically the data ends up being skewed in that way, and then you don't get an accurate picture of what the on-ground situation is in that particular area which the specific Anganwadi covers. So that does make it very difficult.
So it's also the example of manual scavenging. State after state has given a report saying we don't have manual scavenging. There's nobody engaged in manual scavenging in our states. There's zero manual scavenging. So every time a death occurs or if people have to be rehabilitated, when they don't exist itself, then it becomes so even in Karnataka, there's so many people who are identified. There's so many people who are dying in this very casteist, inhuman kind of occupation. But there's absolutely no effort from the state to even rehabilitate or even recognize that this is happening in the states. So what happens is people who can benefit, there are a lot of schemes available. People who can benefit don't have access to the scheme because they don't exist as far as the state is concerned.
So basically a human being made to become a non-entity in the eyes of the state, in which case then they have no access to any sort of, forget about the healthcare, but any sort of, help.
Absolutely.
So caste does play a huge role in access to primary and secondary healthcare. Could you please tell me a little bit about this as well? Because people seem to, just like how you're telling us about how many states sort of deny that manual scavenging still takes place, although it's happening pretty much in the open, where a lot of us have actually seen it with our own eyes. They still deny it. So it's in the same way, a lot of people in their own minds, at least in India, seem to deny the existence of a caste system, or the fact that a caste system is a huge determinant in social welfare. So could you please tell us more about that?
So caste offers disadvantage in many ways at many levels. If even a simple thing like income, the same amount of work, there is data from this NSSO which shows that for the same amount of work, a Dalit woman would get paid less than a woman from the general category. So you start off with that level of disadvantage. Then you also have people with lesser access to land, lesser education, lesser access to housing, and more amount of segregation, longer distances to travel. So if there's like the families which are engaged in manual scavenging, we did some fact-finding visits. And we realized the health workers don't visit the homes of those children. The children are not registered. Children don't receive immunization. Developmental delays in the children are not picked up. And they're not enrolled in the Anganwadi. So the heights and weights are not measured. Malnutrition is not picked up. So it starts off at that level of disadvantage. There's also definitely discrimination. In the sense of children whose parents are engaged in so-called unclean or definitely which are caste-based occupations. First of all, they're not allowed easy access into these spaces. Even where the Anganwadi is located matters. So if you have the Anganwadi situated in a dominant caste area, the children from the other Dalit areas are not allowed access. And then there's also discriminatory treatment at the school level. And in terms of the healthcare system itself, it's not sensitive to the caste issue. People get discriminatory kind of treatment. So if somebody is having reduced access to healthcare because of caste, then the health system has to make proactive steps to bring the people inside. And that definitely is not happening. And even when people come in, the access itself is much reduced. So who are the people who are able to pay? Who are the people who have contacts? Who are the people who have belong to the same class and caste group as the healthcare professionals? All those make a difference in terms of access. And a lot of these social determinants like malnutrition, stunting and undernutrition is more in children from Dalit and Adivasi communities. So they start off at a disadvantage. And apart from that, if you see in the schools, the kind of discrimination they face, food that they traditionally eat is not allowed into the school. They're constantly being told you're dirty, your food is dirty, everything about you is untouchable, everything about you is polluted. What does it do to the self-esteem? Like, and again, when these kids go on to the higher education, there's a whole different range of a different level of discrimination that happens. So it operates at all levels.
So it's extremely evident that a lot of people in our country, our so-called countrymen, our fellow citizens, are being discriminated against on basis of caste in basically everywhere they turn. So
Yes.
whether it's a direct access to healthcare or education or any other determinant that sort of allows a human being to progress through their life, they are being either turned away or discriminated against. So, it's directly or indirectly, it's direct, okay, I mean, it's direct healthcare access, or indirectly where through nutrition or through education or through a lack of these things, they are again being put at a health disadvantage, if there's a term like that. And then they're sort of more susceptible to many diseases, then either they're lifestyle diseases or contagious diseases, because because coming back to their occupation, they are exposed to so many. So for people who don't know that there is something called manual scavenging, I would please urge you to go and educate yourself a little bit. Please do not depend on other people to educate you, because we all have access to information at our fingertips nowadays. And if you see the way that manual scavenging, the very modality of manual scavenging works, they are exposed to sewage, and therefore a host of diseases and contagions in the course of their daily life, and therefore their families are then exposed to it indirectly through them as well. So this first of all, this is an appalling situation that we are sitting by as privileged people, watching this happen in front of us. But secondly, I know there are organizations working for their rights, and to sort of bring them up to some sort of a equal footing with other citizens of this country. But other than that, what can really be done? What can we as privileged citizens do in order to sort of alleviate this very deep, dark situation that a lot of people find themselves in?
So it's not like, if we're talking about like how caste operates in terms of health outcomes and also healthcare. There's an example of I think in 2014-15, around that time, there was a demolition of which was called the economically weaker sections area, like EWS quarters, and there was a demolition and almost 1,600 families were displaced. And we actually saw how the health situation changed. So the first thing they did when they demolished those houses was to destroy the water tank and the public toilets. So just the very fact that people don't have access to drinking water or toilets, people start consuming less water. They actually had to walk quite a distance to use the toilet or to have a bath, and they had to pay money for it. They also lost jobs. The women who are working as domestic workers in the nearby areas were told, don't come. And they couldn't even have a bath and go to work. So a lot of them lost their jobs, and the cost of houses in the nearby areas shot up overnight. So even earlier, if they had to pay an advance of 10,000, it suddenly became 30,000. And with all this, and people were also not able to cook in their own homes. They had to depend on charity, and many of them have shifted to like the outskirts of the city, and we had to spend quite a bit on public transport. They became more vulnerable to domestic violence, more vulnerable to sexual harassment, abuse even by the police, and elderly people lost their medicines. They couldn't buy medicines for diabetes and hypertension. And what we saw is the health situation itself changed. Children started becoming more sick. There were more respiratory infections, more skin infections. So
and deaths as well.
so that's where we met, I think, right?
Yes, yes, and of course, you all of you, I'm sharing photos as well that you can see right now. I'm sharing photos from that incident as well, and yeah. So, and I have seen with my own eyes and spoken to people who have died as a result of a straight direct result of being evicted from their homes, of being forced to live on the street, of being exposed
Yeah.
to the elements, of being exposed to other vectors like rats that carry a host of diseases on their own. Children, like you said, were affected, and I've unfortunately I've attended funerals of people as well who were sort of, I wouldn't say, I'm very tempted to say killed, but okay, let's say who passed on or passed away as a result of this situation.
So if you look at it in that context, and if you were to ask like what should be the role, like you asked, what is the role of
Yes,
people or the so-called middle class? I think first of all, there's a lot of insensitivity in the sense you want the services of people, but you don't want those people themselves. When you talk about smart cities, the people who make those smart cities never figure in your conversation. You want them to come and build and be your domestic workers, your drivers, your street vendors. But then you want to push them to the peripheries and live outside the city. It's like an urban casteism that we can see playing out in front of our eyes. So when you same like what we're talking about, the response to the pandemic, you can't do
right,
a cut and paste or a copy and paste. You have to look at the local context, and you have to look at inclusive growth. You have to look at diversity, and you can't have this vision or a fantasy about a smart city where the poor magically disappear while giving you these services. And the other thing I think is important is for people to have access directly to policy making. There is a misconception that people don't have knowledge, but I think people just don't have access to information, and I think that's deliberate. It's deliberately information is withheld from people, where they're not able to make informed decisions about their lives. And with information, the things that people can do is have agency and have control and be involved in decision making. So I think for the middle class, like you have a lot of people who speak on behalf, like they'll speak on behalf of construction workers without ever having done, construction work in their life. Or they'll talk about domestic workers, or they'll say, oh, migrant workers have all these problems. But there's nowhere you hear the voices of the people who are being spoken about. So also moving out of these spaces, allowing people to speak, giving credit to people's agency, knowledge, wisdom, I think that's important. Because people know what they want, they know how they can contribute, and localizing issues rather than having one central boss or dictator or authoritarian decision-making process. Decentralizing it, I think, will bring better solutions in the long run.
and this is something we see as I can talk about my field as well, as a as someone who the journalist who takes photographs as well. A lot of times we see that people like us are very willing to speak on behalf of other people, to to sort of tell their stories, and we are very
Yes.
self-congratulatory about these kind of things, saying, oh, we are covering these important issues. I have covered these issues myself, but what
Yes.
I realized through my own work as well is this question of agency and of people determining their own their own lives, because ultimately, no matter how many other times I might go into a place like the place that we were talking about, which is EWS, Ejipura, and central Bangalore, there is no way I will have even the smallest bit of understanding about what it's like to live in that kind of housing. To be a domestic worker, to be a driver, to be a migrant laborer. None of us. I mean, I definitely do not know what it's like. So to hear in their own voices and their own from their own minds, more importantly, what exactly they're going through and what exactly they need is extremely important. I think it's something that a lot of people, including people like me, who are so-called content creators, should be definitely thinking about. And also, talking to people like Dr. Sylvia in order to understand what how these things actually work. And especially policy is something, Doctor, you were talking about. This is something we were speaking about a little earlier in the interview as well, how a lot of times the people making policy and, so holding fort on policy aren't the ones really going through these kind of struggles on a day-to-day basis. And we see that now, when now the struggles of a large section of our population through migrant workers or whatever else have been laid bare. Today, just today, we have seen the extreme tragedy of what has happened in Aurangabad, where a train has, run over 16 or even more migrant workers as they were trying to get home. So you see these kind of horrific stories, and now the middle class is slowly waking up and saying, "Oh, their lives are so sad." No, their lives were like this all throughout, from the beginning of the so-called idea of India. But it's just that now, because we are forced to sort of sit at home and see these things, that we're sort of waking up to the fact that these things happen. But these things are happening before, they're happening now, and they're going to happen in the future as well. So, what are we going to do, in order to, so Dr. Sylvia has given us some very important things. The first of which is to listen, keep your eyes open and listen, rather than be the one to try and talk. So I will try and listen to what Dr. Sylvia is saying right now as well. Dr. Sylvia, just quickly going back to the lockdown that's happening right now. Once this lockdown is done, what are the next steps for public health? Let's not keep it too broad based. I'd like to keep it to your area. Once these lockdowns sort of stagger, or they sort of close down, what are the next steps for public health?